I'm Dr. Matt Joosse at Joosse Family Orthodontics in Williamsburg, Virginia, and I have a guest with me today. This is Rebecca Johnson, and she is a partner in treatment with us. Rebecca is a speech therapist, which I think most people understand what speech therapy is, but she's also a myofunctional therapist, and it's the myofunctional therapy that really aids us in our treatment. And so I would love for you to introduce yourself and talk a little bit about what myofunctional therapy is and how it helps me do my job.
Yes. All right. So orofacial myofunctional therapy is, I like to describe it as similar to physical therapy, which is something that a lot of your patients might be familiar with, where we're retraining the muscle patterns of the body. But as opposed to physical therapy, where we think about kind of whole body, legs, arms, your shoulder, we're thinking about the muscles of the face. And so we kind of take the lead on identifying any issues that might be impacting speech sound production, breathing, orthodontic work, and kind of maintaining those orthodontic results. And we provide exercises or referrals to help the patients be successful with their program.
Absolutely. You know, the muscle that I think of the most is the tongue, because some people have conscious tongue habits, but many people have unconscious tongue habits that really make a big difference in terms of not only the growth of the jaws, and so I'd love for you to talk about that, but also how tongue habits can interfere with some of the work that we do.
Yes, so when we think about the tongue as a catalyst for development of jaw growth, we really think about that, especially when kids are younger. So sometimes even before they might end up in your office, we want to educate those families, if I see them first, to help their child get the tongue to live upstairs on the mouth or at the roof of the mouth, because that upward pressure helps the mouth and the jaw to develop more laterally. If the tongue is low and forward in the mouth, a lot of times related to mouth breathing, things like that, that palate, that, the top of the jaw can become really high and narrow. And that's when, you might see them end up in your office because there's crowding or, jumbled teeth, things like that.
Yeah. One of the things that we deal with all the time is impacted upper canine teeth. And one of the big risk factors for impacted upper canines is small upper jaws. And small upper jaws often result from kids that don't put their tongue up in the roof of their mouth. The tongue helps form the roof of the mouth, helps form that size of the upper jaw. And so sometimes we have to go rescue these impacted teeth with surgeries, and we can avoid that surgery by making the upper jaw bigger. Now, we have artificial ways to make the upper jaw bigger with palate expanders, but Rebecca and I have shared an amazing case where we thought this kid was destined for a palate expander, and with some great tongue exercises and teaching them proper tongue posture, we avoided that expander, and his growth and development just kind of resumed as normal. So I think that's an amazing example.
Yeah, that was great. I like to make sure that, especially for older kids, that they don't think orofacial myofunctional therapy can be a substitute for orthodontics. I like to think of it as an adjunct or a supportive role in the orthodontic process, because you guys are going to be the ones who are really able to grow that jaw more easily than us. If we catch them younger, we can help with the expansion. But sometimes in Western culture, it can be a combination of factors, the tongue, but then also what foods did the child eat when they were younger? How is their breathing? Are they getting lots of jaw work by chewing resistive foods? And those sorts of things that we can catch when they're little bitty babies. But then when they're 8 and 9 years old, we rely on you guys in the orthodontic world usually.
Yeah. And so I'll say, it really is a two-way street where you're sending us patients and saying, hey, we really need this palate expanded so that we can be more effective with our speech and whatever therapy. But we're also saying, hey, sometimes we have people with these tongue habits that are preventing their orthodontic treatment from either going as planned, or maybe we see them as big risk factors for relapse. And a lot of times we talk about open bites, people whose front teeth don't come together. And that's often because of a tongue posturing forward. And people like Rebecca can help them give exercises where they don't posture their tongue forward anymore, thus increasing the stability of our orthodontic treatment. So it definitely works both ways.
Yes.
Yeah. Now, Rebecca, you said something really interesting about kind of sleep. And this has been a really kind of hot topic in society in general right now, but certainly in our areas, people are talking a lot about kids and their quality of sleep. So what would you say is kind of one of the things that parents should really be on the lookout for?
I include in all my intake forms a brief screener on sleep quality for pediatric patients. And the questions that I like to have parents think about include snoring, mouth breathing, seeming fatigued the next day, and then some other kind of things that you might not think would be sleep quality related, like extended bedwetting. You have a 7, 8, 9-year-old who is still struggling to make it through the night without wetting the bed. A lot of the instinct might be to treat that behaviorally, but I also encourage families to think about considering a sleep study and making sure that the sleep quality is there, because that can be impacting their ability to make it through the night and stay in that deep, restful sleep as well. Yeah. Tossing and turning, if they're the kid that if you're on vacation, you don't want to, share the bed with because they're elbowing you or kicking around or ending up upside down, that can be an indication of poor quality sleep as well. Those things can be related to airway dysfunction. Sometimes airway dysfunction can be related to that small jaw that we talked about, that really narrow jaw just closes off that airway space. And so our colleagues in orthodontics, if you guys can open up that jaw a little bit, I have seen, with my patients, really great improvements in reported sleep quality and then also associated behaviors because they're getting better sleep. They're able to navigate their day a little bit better, have less behaviors during the school day, maybe maintain attention a little bit better because they're getting that good quality sleep. And then, of course, our other colleagues in ear, nose, and throat medicine would be part of the team as well for those patients.
Yeah, totally. I think that's a great point. Like, we're not necessarily the experts on sleep, but what we are equipped at is we're great people to recognize when there might be these issues happening, because a lot of times it ties into your area of speech, or it ties into some of the things that we see in the mouth. And so let's be really clear. I think if there's one thing that most parents maybe don't know, and I think people are coming to know, is your kid should not be snoring unless they're sick. All right. So that's the one exception. But if your kid regularly snores, that's probably a sign that they're not getting great quality sleep. In my world, we talk about the Fairest 6. This is kind of a screening tool that we use in our office. One of those signs is does your kid snore? Another one that we will often see is if your kid grinds their teeth. Again, grinding teeth doesn't mean that your kid has poor quality sleep, but really worn down teeth is perhaps an indicator that the quality of sleep is not what it should be. And so these are two big risk factors. A small upper jaw would be a third one. And then we have some ideas about the tonsils and the tongue posture and some of the facial shapes as other ones, but those are a little bit harder to see. So for at-home purposes, let's just say this: if your kid snores, if your kid grinds their teeth, and if you see that they have a really small upper jaw, those are probably 3 risk factors that many people could identify. And that would mean that maybe we should get involved. And I'll say this from an orthodontist perspective, we see a lot of kids in general. So we just think that we're a great screening tool because of the number of kids that we see. And of course, a lot of kids come to you for speech purposes as well. So you're a great screening tool too.
Yeah, and I think it's great. And I have seen firsthand the work that your office does that is kind of above and beyond what I might see with other orthodontic practices, where you are really looking closely at, I think this child might have a tongue issue, or I think this child, the parents reported that they're not sleeping well. And that just isn't necessarily something that is always done in every orthodontic practice as that, kind of standard of care. So I think it's great that you're looking at it, your clinicians are looking at it, and making appropriate referrals, because like you said, you see a lot of kids coming in, you're in their mouth, you're able to potentially see some of those signs like tooth wear or enlarged tonsils. And instead of just ignoring it and working with the teeth, you are thinking critically about it and making referrals. So that's great to see.
And I'll say that's where we classically as orthodontists don't get a lot of education in the tongue or tongue posture stuff, habits. We certainly don't learn much about speech. And so these are all areas where your expertise has really enlightened kind of the way that I look at new patients and when I'm going through that exam process. So thanks for helping us out in our exam process too.
Sure,
so I'd love to talk about the 3 ways that oromyofunctional therapy really supports orthodontic treatment. And in my mind, I kind of break this down into 3 ways. One of them is kind of what happens before treatment. And, one of them is during treatment and then kind of post-treatment. And so before we enter treatment, I'm kind of thinking about these 2 cases that I have going on right now where both were cases where the kid had a finger or thumb sucking habit that persisted for many years, often until they were probably 11, 12, 13 years old. And it's been very, very difficult to well, first of all, I should say they started with open bites, so teeth in the front did not come together. It's been really difficult to close these open bites. Almost like even though they don't have that habit anymore, there's some memory in the mouth and probably with the tongue about why that's happening. And so if you want to talk a little bit about kind of how you help eliminate habits early, or even maybe just identifying habits early.
Yes, oral habit elimination is a component of orofacial myofunctional therapy, and that would be a great one for you as an orthodontist to collaborate with us with, because it can be really hard to, those forces kind of counteract each other. Sometimes you're trying to close the open bite, the thumb or the tongue is trying to push against it, and it can be really tricky to either get the results and then stabilize the results. So that's a great one to seek out support for. What I typically do if I have an oral habit case, I always, with any of my patients, I like to think about the why. Why are we doing this? Why are we extended thumb sucking? You know, thumb sucking, oral habit, pacifier, all of those things are, of course, a normal part of development for infants. But once we see those older kids that are still seeking that out, I like to think about what else might be going on. And so a lot of times if the child is using their thumb, they're using it to stimulate the roof of the mouth right behind those front teeth. And that is ideally the spot that the tongue is inhabiting. And so then I have to think, okay, well, why are they using the thumb, or why are they using a pacifier instead of the tongue? And so we kind of unpeel the layers of the onion here and see, do we have airway obstruction? Is that tongue kind of living low in the mouth and that thumb is going right on top of it for that reason? Do we have tethered oral tissue? The tongue can't comfortably live on the roof of the mouth, and so they're pushing that thumb up there instead. So I like to start with the why, make sure we're not jumping in with behavior modification without understanding what else might be going on. Sometimes kids are sucking the thumb, jutting the jaw forward, and that's opening up the airway. And so I don't like to treat, a functional issue with behavioral methods. But then once we get that cleared, and once the child is breathing well and we can start working on those things, then we use, an incentive-based habit elimination program that they feel good about, feel confident about, and they have to be ready for it too. We can't force a 6-year-old to eliminate their thumb sucking habit, because they're gonna say, yeah, Mom, I'm not, and then they're gonna secretly go still do it. And so they have to be ready ready for that process.
I love that you said that. Like, we were trained as orthodontists on how to make these appliances to make somebody stop sucking their thumb, for example. And I even have used this thing called the thumb obliterator, and it's like this torture device, basically. But whenever we see that and we identify that somebody has a thumb habit or some sort of habit that's affecting their mouth, you're right. It always starts with, are you willing to make this change? Because I think that there's a whole social emotional component here that, put a thumb obliterator in, you're not dealing with the social emotional stuff that's going on. You're just making it stop. And so I really believe that. And that's where I always say, we have a partnership with our patients, and that's to treat them like they're our kids. And I wouldn't put a thumb obliterator in on my kid before we started to address some of the emotional reasons why they might be sucking their thumb first. So yeah, I love that you said that. So during treatment, sometimes we have bites, and I'm thinking of something that we call a posterior open bite, where the front teeth all come together, but the back teeth don't come together. And theoretically, it's that the tongue is occupying that space between the teeth. So again, kind of that low tongue posture. Can you just talk a little bit about how you work with those kind of patients to help make our treatment successful?
Yes. So just like any other patient, one of the components of the program would be teaching correct tongue posture, with the tongue resting at the roof of the mouth and not pushing laterally against those posterior molars. And sometimes it can be a tongue toning and shaping issue, where they either aren't able to, or don't consistently narrow the tongue to fit within the arch. Sometimes it might be an arch issue. That would be something that your team would be diagnosing is, oh, we need to grow the mouth because the tongue is never going to be able to fit up there unless we make the mouth a little bit bigger on top. And so ultimately, we're trying to teach the correct tongue pressures of the tongue tip at the roof of the mouth, and pushing upward and not outward, and not down and forward. So that would be how I would tackle it.
I love that you said that. So as a really good point of education for anybody who's listening to this, I think that I want you to, if you're listening to this, think about where your tongue is sitting right now. And if your tongue should just barely be touching kind of the front roof of your mouth. And if you're doing that, it's in a good spot. If it's down and touching kind of below your, behind your lower front teeth, that's probably a sign of low tongue posture and some of these things that we're talking about. So most people don't realize that the tongue kind of belongs up there, and most people do that subconsciously and they have it in the right space just because that's how they don't know any differently. But yeah, always your tongue should be touching kind of the roof of your mouth.
Yep,
So
a couple millimeters kind of behind those central top teeth and the tongue tip there. And then if you can get the remainder of your tongue to rest lightly against the roof of your mouth, that would be ideal also.
Yeah, I love it. So we talked about kind of the before treatment, the mid treatment, and then the post treatment. And again, post treatment, one of the things that we struggle with as orthodontists, especially with people with open bites, and an open bite is when the front teeth don't come together at the start. So people that they can't bite through a piece of pizza because they can't get the cheese and the pepperoni to break off, or they can't bite through a sandwich without leaving the lettuce and tomato behind. I actually had an open bite growing up, so I know this very well. But open bites are really notorious for relapse, in other words, reoccurring. And so this is an area where I feel like you can be of a great help to our patients in helping create stability for those open bite patients. Do you want to talk about maybe why that's unstable and what you do for them?
In an anterior open bite patient, I would really be curious about what the tongue is doing during swallow. Because if this is the roof of your mouth and this is the tongue, if it's consistently pushing forward during the swallow, it can be pushing against those teeth. And just like the braces are providing that pressure to kind of put them in the position that you want them to be, the tongue is providing pressure going the opposite way. And so it can kind of continuously be pushing against those front teeth, causing that open bite to either remain or get bigger and get bigger. And if we can teach the tongue to, instead of pushing forward, stabilize at the tongue tip and push upward during the swallow, then it makes it more likely that the orthodontic work will be stable. And so that's what we want to see. And we swallow, not only obviously chewing and during meals, but one of the things that especially once they've been able to demonstrate that skill with me during liquid swallow trials, chewing trials, then we work on saliva swallows because we swallow saliva, 2,000 times a day. And so that can be a big one. If we don't practice that, then that open bite tongue thrust swallow can continue.
Yeah, one of the big topics in orthodontics these days is palate expansion and how we can make the upper jaw bigger. I am a big fan of palate expansion. I don't do it on every case. It's not needed in every case. But one of the really cool things about palate expansion is that as we increase the size of the upper jaw or the maxilla, we know that we get better nasal airflow. So you should be able to breathe better through your nose after palate expansion. Now, that doesn't mean that palate expansion will cure every problem or every breathing problem, but we know that there's a link there. And so that's been a really interesting thing that we think about as an added benefit to some of the dental effects. I'm curious how things like palate expansion affect speech and how you see that working out in your population.
Yes, I see it in a couple of different ways. From a behavioral standpoint, I've had so many patients who one of their challenges with nasal breathing overnight was because of their narrow jaws. And then once we expanded the jaws, expanded the nasal airflow, they began breathing better at night, and they just became so much more pleasant during the day because they weren't so tired. We as adults, if we're tired, we didn't get a good night's sleep, we can drink an extra cup of coffee or, go buy a soda at lunch. But kids don't necessarily know why their body isn't feeling well. And if that's cumulatively happening for years and years and years, then it can have really interesting and detrimental effects to their ability to maintain attention, their interpersonal relationships, their energy levels. And so that's one way I've seen it. The other way that I've seen it impact is if the jaw is really narrow, if the maxilla is narrow, sometimes the tongue doesn't have enough space to brace laterally to create the correct sound. And I think a lot of times I might see that with the R sound. It's a really common challenge that a lot of kids have, and a lot of my caseload presents with R distortions. And sometimes I'll look in their mouth during the intake and I'm like, man, your tongue doesn't even have enough room to brace laterally and create that tension against those molars to make the sound crisply. And so we had one patient that we shared that one of his treatment plan referrals was to work with an orthodontist and expand the palate. And then you expanded the palate. And then it was pretty quick after that R really cleaned up. That's not to say that will happen with everyone, but if we can optimize the oral structure, then it makes it much more likely that function will follow that.
Yeah.
It's kind of that circle. Form follows function follows form. It kind of goes around and around.
I love that. Sometimes we have people that come to us looking for remedies for speech problems. And one of the interesting things from my perspective is we see mouths that are super jacked up, teeth in all kinds of crazy places. Speech is perfect.
Right.
And then you get people where teeth are in all the right places, bite's perfect, and speech is off. And so speech is obviously so multifactorial. We are not the experts. We are not going to necessarily fix, as an orthodontist, we're not necessarily going to fix all of your kids' speech problems. We can help to create, but that's where I think we need to rope in specialists like you, who have more knowledge about speech and how different sounds are made. And so anyway, I think it's really fascinating how some of these kids have some crazy things happening in their mouths, but they speak totally normal.
I know that individual variation, that, being human, that maybe their tongue range of motion or coordination is a little bit better, but for whatever reason, the teeth, came in a little funky, but I see that, too, as well.
I want to talk about two articles that have come out over the last year. One of them I'll say a little bit more on, and then the other one I'll kind of turn over to you. But there was an article in the Atlantic magazine about, I think it's entitled something like "The Wrenching of Kids' Jaws," and basically saying that everybody's getting a palate expander. Every kid who's going into orthodontic treatment is getting a palate expander, and I certainly don't believe that that's true. Again, I said this earlier, but not every kid in our practice gets a palate expander. I think it's really important to make a good diagnosis. You alluded to this earlier about saying, hey, it's important for us to really investigate each kid and what's going on in their mouths, but a good diagnosis is important. And if expansion is warranted, obviously then we can do a palate expander, but it is not a standard part of our treatment. I want to make that really clear. Palate expansion could be a great adjunct for people like you. And of course, we use that screening tool, that Ferris 6 screening tool, as another guide of who needs palate expansion and who doesn't. There was another article in the New York Times over the last year, and I don't remember what that was titled, but the gist of it was that tongue releases are getting way overprescribed, that it's this factory for people who do tongue releases to make money off of it. And so I'd love for you to comment about tongue ties and tongue releases, and do you feel like this is a big trend right now, and has it gone too far?
First, I'd like to touch on the palate expansion piece. I think that could be, I have a few thoughts on that. One, I think there probably is an increase in palate expander usage. I hope that it is being done appropriately, and I hope that, orthodontists are taking close looks at, the entire patient holistically. I'm also hopeful that orthodontists, that the kind of trend in your world is leaning more towards growing the mouth versus pulling teeth to make those first 6 teeth look good. I think that is one of the things that kind of used to be done quite a bit, pulling permanent teeth. And of course, it makes a great, perfect, straight smile. But then I think a lot of you guys are starting to think more about, well, what whole body impacts is that having? What are we doing to the airways when we're pulling these permanent teeth? So I think as more and more research is coming out and more orthodontists are getting curious about those sorts of things, you're seeing alternatives to kind of the old way of doing things. And so I think it's great that that is happening. With the tongue tie release, I think I'm sure that is also starting to increase in volume, that diagnosis. I tend to be a conservative assessor. I do a thorough assessment. I look at the structures, I take my measurements, and then I typically will, unless it's something where it's like, yes, we obviously need to get it done. Let's go. We're having trouble sleeping. We're having trouble eating. The tongue can't lateralize chew. We got to get this done quickly. Let's prepare for it and then get in. I typically like to see what can be done through therapy first. And if we can avoid an invasive procedure, then great. We don't, necessarily have to have it done. And the release providers that I typically work with, we don't tend to right now make a referral and complete a tongue tie release for hypothetical things that might happen down the road. That's not the way that I am currently, operating as a provider. But I educate the family on, hey, this is a tongue tie to this degree can be correlated with XYZ. And then I put the decision in the family's hands with my information. If they go visit a release provider, they get the guidance from them. And then we make a decision together as a team.
Yep.
And I think the idea that it's a money-making scheme is, I don't know where they did the research for that. I'm not sure. But certainly, not on the functional therapist end. We're not working in the office. We're not, doing the procedures. And so I'm not sure about that.
Yeah.
But I like to look, I look at the child holistically. And I think if that is something that's going to help them achieve better speech, breathing, feeding, that's part of it, then I'll make that referral.
And this is why I've loved working with you. I think you do such a thorough workup of your patients and making really great diagnoses. And we talk a lot about this in our practice. But one of our core values is integrity, and integrity can mean a lot of different things. But treating people like they're your family member is really kind of one of the ways that we define that. And not prescribing things preventatively, not overdiagnosing. Again, making a thorough diagnosis before you prescribe any treatment. And so conservative treatments, trying some of the other things first before we jump into any surgical treatments. I mean, these are all things that I think play into integrity and why you've been such a great partner in treatment for us. So thank you. Yeah.
Yes, I typically will, if the first line of therapy that I'll usually recommend if I see a child that I think, oh, we need to get in right away, it's usually with making sure they can breathe. And so then it might be a colleague, an ENT, or allergies. And those are the ones that I'll be a little bit more like, nope, we gotta go get this checked out. Your child isn't breathing well, versus a tongue tie release.
Yeah. I wanted to talk about a few specific things that are kind of on both of our radars. One of them that's really real to me right now is mouth breathing. This is something that I think sometimes causes confusion that, everybody breathes through their mouth. Everybody should be able to breathe through their nose. When we talk about mouth breathing, at least in my world, we're talking about people that almost exclusively breathe through their mouths, people whose mouths are almost always open. And usually those people are going to have difficulty breathing through their nose. As I said, this is real to me. My oldest son is like this, difficulty breathing through his nose. Mouth is usually open. Can you talk a little bit about why that matters from your perspective?
So, of course, the mouth is one of the gateways to the body, and we are designed to eat and talk using our mouth and breathe using our nose. One of the reasons we want to use our nose for breathing is because it warms and then cleans the air as it comes in, and our mouth doesn't do that. And so if you're breathing through your mouth constantly, you're just not getting the clean and high quality air that you can be getting if you're breathing through your nose. And sometimes those kids are also sick a little bit more because it's not going through that nasal breathing process. And if you're mouth breathing consistently, that tongue is typically low and forward to allow for the air to come in on top of it. And then that creates those other cascading effects from an oral development perspective. Nasal breathing also provides, as the air comes in through the nose, it provides nitric oxide. And that is the way that our brain wants to be processing the air coming in.
From my perspective, when the mouth is open, the tongue is going to be low. You can think about this as you open your mouth, your tongue doesn't usually sit up on the roof of your mouth anymore. It usually drops down. And so if that tongue remains low, again, it's not up in the roof of the mouth. It's not forming that upper jaw to be the size that it really should be. So it matters from a jaw growth perspective, in my opinion.
Yep. And then typically people who are breathing through their mouth during the day are also going to be breathing through their mouth at night. And then, mouth breathing at night tends to be correlated with snoring, potentially obstructive sleep apnea, and all of those things that we don't want to see, especially in pediatric patients.
Another habit that I'd really love to touch on is thumb sucking or finger sucking habits. This is something that we will frequently see and we'll deal with. And I really want to focus more on kind of the effects of those habits, dentally speaking. To be really clear for any parents who might be listening, I had a thumb sucker. My youngest sucked her thumb for several years. We eventually got her over that habit. But the concern with thumb sucking is a couple of things. Number one, that habit can prevent the full eruption of teeth. We'll see kids that, especially when that thumb habit persisted after the adult teeth have erupted, you'll see these weird patterns where the teeth might rise up right where the thumb was or where the fingers were, often creating open bite situations where kids can't bite into things. But the other big effect is that, and I noticed this with my own daughter, is putting the thumb up in the roof of the mouth and creating that suction effect. She's getting more pressure from her cheeks, less from her tongue, which belongs in the roof of the mouth. And then we develop a small upper jaw. Small upper jaw then creates crowding, all these other effects on breathing and so on and so forth. I'm curious how you view these things and what kind of your first line therapies are.
Yes. Sometimes during an intake evaluation, even if the family hasn't indicated that there was a thumb habit, I'll look in the roof of the mouth and I'll look at the shape of it and say, did you ever suck your thumb? And then they'll say, oh yeah, we forgot to put it down. Yes, they sucked their thumb until they were 4. So it can have lasting effects. I can see that in the roof of the mouth of an 8 or 9-year-old, even if they have eliminated the habit. One of the first things that I think about with a patient who has an extended oral habit is the why behind it. So we talked a little bit before about not necessarily jumping into behavioral methods until we understand why the habit is there. Once we've understood and once we have, if it's an airway issue where they're, jutting the jaw forward while they're sucking the thumb so they can breathe around the thumb, once we've taken care of that, then we can start tackling things from a behavioral and motor teaching perspective. And I have my little mouth puppet. But what can happen with thumb sucking, or what typically does happen, is the child is using the thumb to stimulate the roof of the mouth behind the top teeth. And that roof of the mouth behind the top teeth, the fancy word for what they are typically touching is called the incisive papilla. And it's where a lot of nerve endings are. And it feels good to have that part of the mouth stimulated. I tell kids that when you touch that with your tongue, it releases happy chemicals in your brain. And what we try to do as orofacial myofunctional therapists, as we're eliminating a thumb habit or a pacifier habit, is get the tongue to do that job instead. And so teach the tongue that the tip of the tongue should be touching that incisive papilla, not the thumb. Because if if the tongue is up there, the teeth are, able to be in the correct position and nothing is pushing them. But with that thumb constantly pushing up there, just like you said, you see those effects of maybe an open bite or maybe other funky things. I've seen kids come at it from the side or like 2 fingers coming in. Sometimes they have additional things that they do with it. So they might always suck their thumb and twirl their hair at the same time. And so we have to kind of tackle both of those things because they can have impacts socially as well. And so that's what we tackle the why. And then I'll give specific exercises or activities to encourage the tongue to replace that oral habit. And then obviously, working collaboratively with partners in orthodontics, partners in ear, nose, and throat to make sure that those other factors are being addressed as well.
The other thing that happens from my perspective is as a thumb habit persists and we get that small upper jaw, the bite actually will, the body's so interesting how it tries to adapt to things that are off. And so kids will often adjust their bite, but they'll always shift their bite to one side repeatedly, habitually. Every single time that they bite down, that jaw shifts. And what they're actually starting to do is to grow an asymmetric lower jaw. And so we have these growth patterns that kind of go off course from the thumb sucking. And so it's not just about tooth position and things like that, but it's also about jaw growth. And that's one of the really important things that we can intervene on when kids are 8, 9, 10 years old. While we're on the topic of thumb sucking, I thought I'd just mention a few of my kind of favorite things to try. They're very, very easy things. So Novella Stop is a thing that you can paint on your fingers. It tastes bad. And I think it's a great, $10 investment, something to try. The other one, Rebecca, you mentioned how stimulating it is to touch that incisive papilla, that area on the roof of the mouth. And that's, I never actually, I know about the incisive papilla from anatomy, but I never really learned about how stimulating that is and why that's a factor in oral habits. Sometimes we find that kids also get stimulation from their digits too. And so we've purchased these little things on Amazon, these little finger fidget things, and And so kids with a thumb habit, sometimes we give them these and they roll it on their thumb and they get that same pleasure from their thumb that they do when they're sucking it. And so again, this is a $5 Amazon investment. So there are some really easy things to try kind of before jumping to any oral habit appliance or anything that's more severe. And so we always like to try these.
I know, I hadn't seen those.
We'll things.
Sometimes wrap the thumb in something that makes it like not feel good to put in the mouth, but that's probably more pleasant for the child to have. So I'll have to look into that. And then also the foul tasting things. Those are the behavioral methods that we talked about. After the other things are cleared, then we can start incorporating some of those because we don't want to make the kids feel bad if there's a reason that they're doing it.
Right. Yeah, the other really low budget one that I tell people about is going out and buying a tongue depressor. Tongue depressor is basically like a medical version of a popsicle stick and kind of taping that to the digit that they like to suck. And again, just at nighttime, it's a great reminder. You don't really want to put a piece of wood into your mouth.
Yeah.
So it can be an easy.
That or like I'll have them take like one of dad's socks and they'll put it on whatever the hand is that they suck. And then we'll like tape it to the pajamas. And then they like definitely don't want to put that in their mouth overnight because sometimes overnight can be really tricky. That's the time when they're trying to calm their body down and that's the thumb really wants to go in at that point. And so that's when you might incorporate those behavioral methods. And then we incorporate positive things too. So we have the things that are going to kind of be negatively associated, but then during my program, they'll also be working towards a big party where they get to have, a big gift maybe that we, mom and I work together to choose. One of my patients who eliminated a habit, we had a big tea party for her last session when she had decided and she hadn't, used her oral habit in about 6 weeks. And then we're like, okay, let's do it. Let's have our party. So having that positive thing to look forward to. And then they feel really proud. They get a little certificate and they know that they don't suck their thumb anymore and they don't have to worry about it at a sleepover. And so, that is part of it too.
I love that. You said something about how attention, the idea of how our brains function, our cognitive ability may be related to sleep. And I think there's a really interesting thing out there about how ADHD, we don't fully understand ADHD, but ADHD may not be an attention disorder. It could be a sleep disorder that when we're not sleeping well, we have problems focusing and learning and things like that. So I think this idea about quality of sleep is so important. And so I'd love for us to kind of review maybe from our different perspectives, what are the risk factors? What are the signs maybe that people can be on the lookout for of, hey, my kid may not be sleeping as well as they should be?
Yeah, that's something that for every new patient evaluation that there are screening questions that I will ask the family just to, even if they're not coming in with oral function concerns, sometimes we'll find them during that process. And I'm trying to remember what they are, but some of the main ones that you as the parent can be looking for with your child include snoring, mouth breathing while sleeping, tossing and turning, grinding the teeth. Sometimes that can be hard to hear. If you're trying to listen, you might not hear it, but a lot of times at those dental appointments, you can inquire. The dentist is likely going to tell you if they're noticing it, but you can also inquire if there are any signs. Waking up feeling unrefreshed, being really sweaty, overnight. That means you're kind of really tossing and turning in there. And then surprisingly, extended bedwetting can be correlated with that too. And that's something that a lot of kids feel really badly about. And they feel like something's wrong with me. Why am I doing this? I'm acting like a baby. And it's like, well, you're not doing it because you're bad. Like you're probably doing it because your body isn't getting into that deep sleep and turning off all of those, signals that you need to urinate. And so that if we can get that fixed, then we might be able to improve that symptom as well. So those are the things that I might see. Do you see similar things?
Absolutely, yeah. When we see teeth that are really ground down, especially at really young ages, that's an automatic kind of red flag where we need to start investigating a little bit more. We'll usually ask about snoring in those situations. We look at the size of the palate. A small upper jaw is going to be a really big indicator. And yes, kids that are come in and they're almost like that Darth Vader mouth breathing. These are all kind of really big warning signs that we have. But yeah, I think if your kid exhibits any of those signs, there are lots of starting places. Again, we're not the experts on all of those things. We like to use ENTs. Might be good to incorporate your pediatrician in some of those things. But again, we just serve as good people to identify some of those risk factors and be able to help in the ways that we're able to help.
Yes, and when I'm working with a patient who has those concerns, if I'm referring to an ear, nose, and throat doctor, if I have significant sleep concerns, I will typically include in my referral, a list of the different things that I'm seeing, because you want to make sure as a parent that your concerns are heard. And so don't be afraid to get a second opinion. If you go to an ear, nose, and throat doctor because you are worried that your child isn't breathing well or sleeping well, and you feel like it isn't being taken seriously, either by the ear, nose, and throat doctor, by a pediatrician, by any medical professional, follow your gut. You know your child best, and don't be afraid to seek a second opinion. If you have those concerns about snoring, breathing, poor quality sleep, is worth investigating, and continue working to get answers.
Thank you so much for spending some time with me today. Every time I talk to you, Rebecca, I learn new things. And I had mentioned this before, that we as orthodontists just are not classically trained in a lot of the things that you were trained in. It makes you such a great adjunct to us. I love using you as a great resource for our patients. And we talked about how we use you for patients that haven't yet started orthodontic treatment, patients that are currently in orthodontic treatment, patients that are finished with their orthodontic treatment. All of them can benefit from your services. My one son is going to be seeing you very soon here. So that's my personal plug and trust in you as a provider. But I think you make just amazing diagnoses, great workups. I really enjoy when I see those things come in on my inbox. And so can't say enough good things about the work that you're doing. Thank you for taking care of the kids of Williamsburg and our surrounding areas. And I just say, great job. Keep up the good work.
Well, thank you. And it has been such a pleasure to collaborate with your office as well. I've been a speech pathologist for a lot of years, taken advanced training in orofacial myofunctional therapy, and worked in a few different locations, and a lot of orthodontists just aren't interested in it. And so to find someone locally that is he's curious and he wants to know, and he's doing sleep screenings for his patients, that's just not part of the typical orthodontic workup that a lot of us might be seeing as orofacial myofunctional therapists. So we're very lucky to have your office locally, and I've been really pleased with the care that my patients have taken, that you have taken with my patients. They not only have good results orthodontically, but everybody raves about your practice and how you guys take care of them. So it's been great having you guys as well.